Thank you very much, and it's my pleasure to be here. I want to thank the organizers, Peter, very much for the kind invitation to be here. I'm going to summarize for you in 10 minutes about a year's worth of work here in bringing together this consensus on definitions. So we're talking about definitions related to prevention of stroke in the context of cardiovascular procedures, whether they be surgical or interventional. Let's see, okay. Here are my disclosures. I think the main disclosure here is that I'm a cardiologist. I'm not a neurologist. So as we go into the definitions, you'll see there was a lot of input from neurology. So this takes us back to TAVR. As you know, there's been a lot of work in the last decade looking at outcomes, stroke outcomes, neurologic outcomes in the context of both surgical AVR as well as TAVI. And the observation that we made as we were looking at neuroprotection devices is that the stroke rates really depend on the definition you use. So in the clinical trials, the randomized clinical trials that you're familiar with and that you see in publication, the stroke rates range up to about 6%. What we're talking about are severe strokes. If you include, as would suggest the American Stroke Association, if you include mild and moderate stroke to severe strokes, what you can see is that the stroke rates, in fact, are much higher in the range of 15% and above. The other issue in these studies is that typically at the beginning of the saga of TAVR, the cardiologist was making the assessment of stroke. So the cardiologist is probably not the best person to do a neuro exam, as I'm sure you're aware. So what we've learned also, based on your imaging, and this is diffusion-weighted MRI, is a patient going for TAVR, for the most part, majority of patients will have evidence of brain embolization. So multiple infarcts, as you can see here, and relatively large areas of infarction. As you very well know, these have been associated outside of the context of TAVR with subsequent dementia, cognitive decline, and in fact is a marker of subsequent stroke. This is a recent study called the Sentinel trial, looking at a neuroprotection device. It's a filter device. And this is looking at the histopathology of the debris captured during the procedure. And you can see that every single patient that had this protection device actually had debris captured, that the size of the debris was large. And you can see, based on analysis of what was captured, that there's a whole host of different things that are being captured in these baskets, including arterial wall valve tissue, foreign material. So catheter material is being captured in these baskets as well. So while we focus on TAVI, and TAVI is out here and clearly seems to be worse, this is not unique to TAVI. You can see that pretty much any manipulation of the heart will lead, whether it be surgical or endovascular, will lead to embolization and a risk of stroke, as we know. This is just beautiful simulation from my colleague Rob Schwartz, basically showing that about a third of blood circulation goes straight to the brain. So as we do our TAVI procedure, we're embolizing to the brain, and there's a preponderance for the innominate and the common carotid, but also left vertebral is affected. So if we look back in history and we look at all the cerebral protection devices that have been evaluated, whether it be in the context of surgery or TAVI, we have many failed trials. Many failed trials. In fact, there is not a single study that has looked at neuroprotection that has been positive. So why is that? Is it that the devices don't work? So maybe it's just that these devices are not effective. We haven't come up with a solution to treat the brain and protect the brain from embolization. But I think that we need to ask ourselves the question is whether this is really more of a trial design issue. And I've shown you that there is a lot of issues with defining stroke. And as we've looked over the last day at all the stroke rates, what is that stroke? What does it mean? What are we looking at? And then in the context of cerebral protection, we love surrogates because surrogates actually reduces the sample size. But when we go to diffusion-weighted MRI, we don't really understand which endpoint we should be actually measuring. Should we be looking at frequency, volumes? We need to understand the variability of the measurements, the clinical relevance. Is it the volume? Is it the location, etc.? This is a pooled analysis that I did and presented a year or so ago, simply showing of a neuroprotection studies, simply showing that depending on how you define this, you can choose what your incidence. So whether you're looking at stroke disability, major stroke, mild stroke, cognitive decline, or covert stroke based on imaging, you can see you can dial up from 0 up to 100%. So clearly, if you're looking at neuroprotection, you want to have some sort of clinically meaningful measure, and you want to have a sensitive measure to be able to detect a difference, right? So this is actually very relevant. So this is the reason why we decided to, I went to the FDA, and basically they are as challenged as any of us in interpreting these data. They were thrilled to have the opportunity to build a consensus. And that was sort of the rationale behind doing this. So what we were proposing to do was to assess, measure, and classify neurologic endpoints that were associated with cardiovascular procedures. We put together this group of 40 different individuals representing Europe and the United States. Some of the members are in this room. And you can see the specialties, so interventional, structural, CT surgery, but a lot of input with our neurology colleagues, neuroradiology, neuropsychology. We had representatives from the NIH, NINDS, and of course the FDA. So Brahim Zuckerman is the branch chief. Carlos Pena is the head of the acute stroke interventional area. And, you know, just to put this in context, while this has to do with defining strokes in the context of cardiac procedures, the FDA is very interested in acute stroke intervention and those definitions. So I bring that to you to consider as you move forward. We met twice. The whole group met twice to bring this consensus together in October of 2015 at TCT in San Francisco, and a second time at the Yale Club. This is just a picture to capture the moment. It was absolutely wonderful, very academic discussions. So, take-home message number one. I think it's important to realize that the neurologic evaluation and endpoint selection needs to be tailored, needs to be specific to the type of procedure and device category. We identified 3 categories of devices. Procedures where there's an inherent risk of stroke. Those are category 1, where neurologic endpoints are actually a safety measure. Category 2 are devices that are intended to protect the brain. So you're talking about effectiveness, efficacy. So that's what we need to focus on. And category 3 are combinations, so safety and effectiveness. And the prime example here, PFO closures or left atrial appendage closure devices where you have a risk up front, but the device is intended to reduce stroke. So here's our classification. Believe it or not, it took us about a year to come up with this. It's really simple. It's very comprehensive. And I think it's very relevant and practical to patients. So 3 types. Type 1, we call overt CNS injury. These are acutely symptomatic patients. It's your typical ischemic stroke, hemorrhagic conversion, the hemorrhages, and the hypoxic ischemic injury, very relevant in the context of cardiovascular procedures because of hypotension, hypoxemia, etc., and the worst prognosis that is associated with this. Type 2, we call covert CNS injury. These are acutely asymptomatic, but as I mentioned, we don't know what happens down the road. You may have long-term cognitive decline, but we identify injury based on imaging. So of course, you can have, once again, infarction and hemorrhage. And then type 3 are neurologic dysfunction, but no injury based on imaging. Right? So they're symptomatic, but there's absolutely nothing on imaging. That's your TIA and delirium. So delirium was something that came out of this consensus that was important. Either delirium with no imaging injury, which actually has a worse prognosis than not having delirium, and then the fact that delirium is actually the presenting symptom of stroke in many perioperative patients, and where we recommend actually doing imaging in those patients. And until now, I can tell you on the interventional cardiology side, is typically not the practice. So this is sort of, a graphic of what we're talking about with covert injury here, symptoms without injury, overt injury, so really a pyramid, and the application and assessment. So if you're looking at a safety trial, it's imaging that's based on symptoms. If it's an effectiveness trial, you want to have imaging done in all patients, and then screen patients for symptoms to try and dig into and better understand covert injury. The critical thing, and this is what the FDA said from day one, is that you need to be consistent with historical definitions, and we are. If you look at our composites, we're entirely consistent with the American Stroke Association. We're entirely consistent with VARC2, all type 1 overt strokes are VARC2 strokes. So consistency with historical definitions. We came up with classifications for acute severity. Typically, this is not assessed in our trials. How severe is the acute stroke based on the NIH stroke scale? Long-term disability, we added fatal stroke and stroke with complete recovery. This is very intense slide with a lot of recommendations in this document as to how to assess, when to do imaging. I'm not going to go into the details of this, but you can go to the paper. One word here about diffusion-weighted MRI and the endpoint. The timing is critical. We learned that if you do the assessment at 2 days versus 3 to 7 days, there is so much signal attenuation that this will impact the power calculations in your studies, and probably the reason why some of our trials have been negative. The timing of assessment after a procedure is critical. The FDA wants us to do this at 30 days. We don't see a difference at 30 days. If you look at outcomes at 72 hours, though, we do see a difference. So isn't this important? Shouldn't we be assessing as a primary endpoint our endpoint earlier? I think this is key. This again shows that at 7 days we're seeing differences. Again, a beautiful graphic here showing procedure here, the embolic debris, and then basically the ongoing risk of the patient. We have looked in our own study, NeuroTAVR, that if you look at NIH stroke scales, both at 30 days versus earlier, you can see a difference. Actually, you're detecting more neurologic signals earlier on. So earlier endpoints may be better in this context. So I'm just going to wrap up here. This is the publication, came out this time last year. And again, I would urge this group to consider doing something very similar in acute stroke intervention, because I think there is a need for it. Thank you very much.